I'm Vicky. I'm one of the PoTS UK trustees, and I'm joined today by Melloney. She is a Syncope and PoTS nurse specialist, and she's joining us for a webinar today about practical tips for PoTS patients. If there's anybody that's got any questions that you want to ask Melloney, do feel free to drop that in the Q&A box. You'll find that on the bottom of the screen. Feel free to chat amongst yourselves as well in the chat box, and then at the end of Melloney's presentation and her slides, she will go through the Q&A section. But thank you everyone for joining us today, and I'll hand over to you, Melloney. I will be on mute, but I'm on hand. If you need me for anything, just shout, and I can jump in where you need me.
Okay, thank you, Vicky.
You're welcome.
Just to introduce myself, I work in Sheffield, and I am the lead nurse for the Syncope and PoTS service there. And I've been looking after patients with PoTS for about 10 years now. So we've got a lot of experience in dealing with patients with PoTS and patients with other forms of chronic orthostatic intolerance. So the idea for the webinar came up really to talk about the specialist clinic, how to prepare yourself for the specialist clinic, but also to answer some questions that are frequently asked through the PoTS UK support email. And I'm one of the people that answers those emails. And there are some questions that come up time and time again. So I thought it might be a good idea to sort of just give people a bit of an idea as to what those answers might be. So one of the questions that a lot of people ask on the PoTS UK enquiries is, do you think I've got PoTS? Well, the problem is it's very difficult to answer that on an email. So what I thought I'd do is a quick resume and how to get referred into a specialist clinic. So what is PoTS? I'm sure lots of you are familiar about this, but it is one of a group of disorders that have orthostatic intolerance as the main symptoms. So there are other disorders that have orthostatic intolerance as the main symptom. PoTS is just one of them. In our clinic, we don't mind if you've not got PoTS. We're happy to treat people who've got all forms of chronic orthostatic intolerance. So orthostatic intolerance is the development of symptoms when you stand up, which are reduced by reclining. And like I said, there's several types. So PoTS is particular because it's due to an abnormal response of the autonomic nervous system. So that's a nervous system you can't control, in particular the heart rate on standing. And it predominantly affects women between the ages of 13 and 50 years. It's a ratio of about 5 women to 1 man. So lots of people ask on the PoTS UK enquiries, where can I go? How can I get diagnosed? So how is PoTS diagnosed? We see lots of patients who've been told they've got PoTS and it's been diagnosed on a heart monitor. And people might have a suspicion that it is, but really it needs diagnosing properly and making sure that we have got the diagnosis correct. So you diagnose it by doing a thorough history and assessment of the patient. Now, obviously in today's world, this is all over the phone, which makes it a little bit more difficult, but you can get a good idea of what's going on. The diagnosis is made by active stand or tilt table test. In our service, we prefer tilt table test. It gives us a good idea of what is really going on when the patient stands up. You must have had symptoms longer than 3 months, possibly up to 6 months. People say between 3 and 6 months. Now, one thing that must be excluded before you give the diagnosis of PoTS is that the increased heart rate on standing is not due to something else. We see lots of patients where they've got other conditions where the heart rate could be increased by that. So things like deconditioning, adrenal insufficiency can cause low blood pressure and high heart rate. Anemia, so the lack of iron, can cause low blood pressure, can cause you to be short of breath, can cause you to have a high heart rate. Thyroid problems, and then some patients have functional or non-epileptic seizure disorder, and quite often on tilt table tests you see that the patient's heart rate goes up a bit and they pass out, but actually there's no real big alterations in heart rate and blood pressure. Medications is a big one. Patients who are on ADHD medications, SNRIs, amitriptyline, all those cause increase in heart rate. So it's difficult to diagnose POTS when patients are on those kind of medications. And really, in order to get the diagnosis correct, you need to be able to perform an active stand or tilt table test when patients are off those medications. Anxiety can cause increased heart rate. Now, in my experience, lots of patients come to our clinic with anxiety, but the anxiety is caused by the symptoms, not the symptoms caused by the anxiety. So, I mean, there is that whole psychological thing to go into as well. And often patients who've got a low BMI can have so that's body mass index, can have an increased heart rate on standing as well. So people with eating disorders. So it's really important that those things are ironed out and make sure people haven't got those things before you give the diagnosis, because you're diagnosing and labeling someone with a chronic condition. So recently, the Canadians have put out a consensus document that has redefined how we diagnose POTS. And actually, me and my team have found this very useful. So the diagnosis of POTS is made when someone stands up. They have to have an increase of heart rate of more than 30 beats a minute, so 40 beats a minute in teenagers, within 10 minutes of standing, which is sustained in the absence of orthostatic hypotension, so no low blood pressure with symptom reproduction. So it's quite specific, that. And what we find is we get a lot of people come to clinic who've been told they've got POTS and actually don't meet that criteria, but do have orthostatic intolerance. And we can still treat that. It's just not called POTS. And things like people might have an increase in heart rate on initial standing and then it settles down. And again, that's a bit more orthostatic intolerance, the other forms, rather than a POTS response. And we feel, and I think POTS UK feel, that these conditions are best managed in a specialist clinic. So even if the patient who comes to us hasn't got POTS, we're still happy to treat them if they've got an orthostatic intolerance. And the Canadian consensus document does start to relabel a lot of these conditions that are caused by other forms of orthostatic intolerance, which is quite helpful. So one of the things that we get a lot of inquiries about on the website is, where can I get diagnosed and how do I get referred? So first of all, there is a list of doctors on the website who specialise in looking after POTS. Now, there aren't many of them, and there certainly aren't any of them in Scotland or Wales. And this is a big problem, and it's something that I know POTS UK are trying to tackle, but it's something that's not going to be amended or dealt with soon, because people have to have an interest in it and then register that they're interested. So quite often patients end up travelling a long way to see a specialist, but in my experience, they usually find it well worth the visit. So I've put the link on here, so if people want to take a screenshot of the slideshow, then there's the link there so they can go straight onto the doctor's list and look to see which is their closest doctor. Now, all referrals really need a referral letter from the GP. Whether you go NHS or private, it is a good idea to have a referral letter. So I'm afraid you will have to discuss it with your GP. Now, the problem is some people have GPs who are absolutely lovely and they're quite happy to discuss this with them and they're quite open to suggestion. And some people have GPs who just have a closed mind about it. And it's really difficult. And we see lots of patients who've had to change GPs to get themselves referred into our clinic. But I think the best way to go about it is to go to your GP armed with some information. Now, obviously, in today's world where everything's doing over the phone, it makes it a bit more difficult. But I think in the old world, we would have taken perhaps a sheet of paper in, perhaps this one that I've linked us to, for the GPs to read. So the referral letter is really important. If you go privately, which obviously you have to pay for, you don't necessarily have to have a referral letter, but it's not really a good idea to go to see anybody without a referral letter, because your GP will write on it things that are really important for the clinician to know and see, and can make a big deal of difference. In fact, it's not really very safe to see someone when you don't need all the details. You need all those little things. So NHS, obviously your GP refers you, it's all paid for by the state, whereas private, you have to pay for it yourself. Now, we've had quite a few patients who've had to privately fund going to see an EDS specialist. And some patients have done it by crowd surfing and found quite innovative ways of getting the money together to see someone privately. Now, we get a lot of second opinions in our clinic, with us being quite a big centre. And if you are a patient in the NHS in the UK, you are entitled to a second opinion if you're not happy with what's going on or happy with the management plan that you've been given by the person you've been given it by. So you can ask your GP to refer you to for a second opinion if you're not happy. Okay. So the role of the specialist clinic is really to give advice and tips on how to manage your symptoms. So we'll see you, take a history, which I'll go through in a minute, give lots of advice and tips. Listen, lots of patients have had a very long journey to get to the clinic. They've been pushed back, they've gone from pillar to post, they've been discharged, they really don't know where they're at, and they want someone to listen to them, support them and reassure them. And that's what we try to do. We try to have an ongoing relationship with patients so that they feel that they can phone us and ask questions if they're ill, if they need to go in hospital for something, and they can just ask our advice about that. We do understand the symptoms usually. Sometimes people have symptoms that we've never heard of before, and we're usually quite candid and say, I haven't really heard of that before. We're usually able to explain symptoms and why they happen. We're often able to give a diagnosis after tests. We oversee the medications, so if we feel that non-pharmacological sort of methods aren't doing their best, then we would advise medications and oversee them being started and making sure you're all right on them. We often have to suggest referrals to other specialities, so such as we often refer people for psychological help, because having a chronic illness, even with the toughest of person, having a chronic illness can make people feel very low. And so we, in Sheffield, we have a really good IAP service that offers really good courses and one-to-one sessions, and they've been to our clinics and they know what our patients are up against. So other specialities that we often refer to: gastro, immunology, rheumatology, almost all the ologies actually, we would refer if need be. And then the other way that we give support is to schools, work and benefit claims. And quite often patients need letters for exams at school, because we see patients who are 16 and above. So for exams, how to do exams, do they need extra time, all that sort of thing. For work, if people need to flexibly work from home, if they need to go part-time, if they need more allowance to get fluids and salt in their day, and then benefit claims such as PIP. So when people first come to the clinic, this is what to expect. You'll be asked lots of questions about your symptoms, and patients usually go home a bit sort of tired really from how many questions we've asked. The appointment will last 40 minutes to an hour. In our clinic, we're allowed 45 minutes, but often it takes longer than that. So prepare yourself, think about your symptoms, when they happen, what makes them worse, better, what are your symptoms, write them down. Most people forget about them when they come through the door. If you've had tests anywhere else, see if you can bring copies along. It's really hard to get copies of people's tests sometimes, and our clerical staff can spend hours chasing tests. So if you have had tests elsewhere and you can get copies, bring them along and then we can put them in your notes. It's really important that you bring someone else along with you, particularly if you've had transient loss of consciousness, because they'll be witness to that and they can tell us what happens while you're unconscious. Any questions, write everything down. We can go through the list with you, that's fine. Be prepared to undergo further tests. Quite often patients have had tilt table tests, etc., in different centres where they don't use beat-to-beat monitoring, and that can be really difficult to interpret those. So we quite often have to send patients for tilt table tests again. Also, patients will often have their tilt table tests on medications that we would prefer them to be off, so we can get the diagnosis correct. You probably won't get all the answers at your first visit. the journey of treating POTS can be quite long and slow, as I'm sure people realise, but hopefully we'll be moving in the right direction and cover things in subsequent appointments. So these are the things to expect that we'll ask you in clinic. We'll ask you about other medical conditions, your medications, what dose you're on, when you take them, what time of day. Family history, is there anyone else in the family that has similar symptoms? Is there a family history of sudden cardiac death? Are we missing something? We need to make sure that we're absolutely on the money here and we're not missing something that is life-threatening. We'll ask you about driving. Are you driving? Have you been advised not to drive? We'll ask you about activity. Are you bedbound? Are you not getting up much during the day? Are you walking? Are you doing activity? And we'll ask you how often you eat, what you're eating, how much fluid you're taking, your salt intake, your alcohol intake. And we will ask you about your mood and how you're feeling about things. From a symptom point of view, we will ask you about transient loss of consciousness, so fainting, blackouts and passing out. So think about when you've had them. Have you had them standing, sitting, lying? How long you've been unconscious for? What other people have said about it? How frequent they are, when the last episode was. Again, feeling faint, dizzy, lightheaded. Again, how often, how frequent? When was the last episode? Is it when you're standing? Is it when you're sitting for a long period of time? Think about all those things and write them down. So lots of people come to clinic saying they have palpitations, but they're not aware that palpitations is actually awareness of your heart beating and it's not a diagnosis. So we want to know when you're aware of your heart beating. Is it that you feel like you've had a missed beat, an extra beat? Do you feel your heart pumping harder? How often it is? What are you doing at the time? And how long it lasts for and what makes it go away. The same for difficulty of breathing and feeling out of breath. Are you short of breath going up the stairs? Are you short of breath talking? All those sorts of things we need to know about. And then chest discomfort is something that lots of POTS patients suffer from. And we need to know when it happens. Does it happen when your heart rate's feeling like it's going up? Is it stabbing? Is it aching? Where is it? How long does it last for? When does it come and go? So all those things we'll be interested in. Other things we're interested in and we'll ask you about is your sleep pattern. What time do you go to sleep? Do you have problems getting to sleep? Do you have problems staying asleep? When you wake up in the morning, do you feel like you've had a good night's sleep? Do you feel fatigued or tired? So there's a big difference between fatigue and tiredness. Tiredness, you feel like you just need a good sleep. Fatigue, you feel like you've got the weight of the world on you, you're dragging your body around, it feels leaden. So we need to know about that as well. So we also need to know about temperature regulation and sweating. So are you hot when it's hot? Are you cold when it's cold? Or are you completely opposite? So when it's hot, you're freezing. When it's cold, you're boiling. Do you sweat normally? Most people sweat under their arms. But are you sweating in funny places? Do you sweat on your back but not your front and things like that? And do you think you sweat excessively? Or we have quite a lot of patients who don't sweat at all. So we need to ask you about your bowels. Lots of patients who are hypermobile have problems with the bowels. Do you feel nauseated? Do you get full quickly? Do you have constipation, diarrhea, bloating? All that sort of thing is useful. Also useful is what's happening with your bladder. Again, people who are hypermobile often have problems with the bladder. So do you get urgency to have a wee? Do you get frequency? Do you need to go quickly? Do you get urgency? Like, I need to go to pass urine and it's got to be now. Do you get leakage? All those things. And plus, do you get lots of urine infections? From a joints point of view, of course, we're interested in the joints. We all know there's a strong association between hypermobility and POTS. So currently, it's very difficult to examine patients because we're doing all this on the phone. But we like to know whether you dislocate, are you having painful joints? Were you a bit of a gymnast as a younger person, a dancer, someone who could touch the toes, do the splits, that sort of thing. And whether anyone else in the family can do that as well. And then rashes and allergies, we like to ask, do you get rashes? Do you get allergies? Do they come out of nowhere? Where do you get them? What happens? And the only other thing that I've not put on here is about people's menstruation and whether symptoms get worse. Then I find a lot of patients with POTS get a lot of symptoms around the time they have the period, but also have quite heavy and painful periods as well. So top tips. The top tip that we will give in clinic is fluids and salt. Now, it's difficult for some people if you've got gastroparesis, so problems with your bowels due to hypermobility. It can be difficult, but can be very effective. And I would say that at least 50% of patients that we see have some resolution of symptoms with fluid and salt. And certainly I know from the Facebook survey that was done by POTS UK recently, most people said fluids and salt was the best tip that they were given. So following on from Helen's talk a few weeks ago, 3 litres of fluid a day, a teaspoon of salt a day. And the problem is that if people aren't able to do that, we're never sure whether the symptoms are there just due to dehydration, but also the medications that we give rely on that to work. So it is really important if we can do that to do it. Other tips that we will give in clinic after the first visit, we talk about compression tights. So the further up the compression goes, the better. And this can stop pooling of blood in the legs. And what we would suggest is that people buy a standard pair of compression tights first, like from John Lewis or Marks and Spencer's or wherever, the strongest pair you can get, and see if you can tolerate them, because the next step is a pair that orthotics will provide, and they are hard to get on and very tight. So if you can't tolerate them, it's not even worth going there. Whereas if you can tolerate them and know you can by trying on a less strong pair, then we know that we can go down that route. Counter manoeuvres, there's lots of advice on POTS UK about pumping your calves, clenching muscles. Always make sure you sit down if you feel dizzy and lightheaded, put your feet up, all that sort of thing. Now, psychology is really important because lots of patients have had a very long journey to get to the specialist clinic. And even, like I said before, even the strongest and most robust person can feel low with this. The problem with the psychology and the emotional side of it, it can often feed into the symptoms and make the symptoms worse. The relief people feel when they get to a clinic where someone knows what they're talking about can be absolutely palpable in the clinic room. And some of this helps alleviate some of the psychological issues. But if there are psychological issues, they are best to be addressed. And I think any person would feel low and anxious about these symptoms if they were unexplained. Once they start to be explained, it helps alleviate some of those symptoms. But it's always best to address these. And like in Sheffield, we have a very good IAP service. They offer lots of courses and lots of one-to-one. And we've had enormous success by people engaging in this. And it's helped stop that vicious cycle of the psychology, the low mood, the anxiety and everything feeding back into the symptoms and making the symptoms worse. Diet, I think Helen covered that really well a few weeks ago. You know, people can choose lots of diets. One thing that we looked at in Sheffield is we did a study on patients who had bloating and symptoms and found that at least 40% of patients who have POTS are gluten intolerant. And once they go on a low gluten diet, it alleviates a lot of the problems. But some people are lactose, dairy intolerant, some people follow the low FODMAP diet, some people vegan and vegetarian. But I think it is really important to say that whatever the diet, we need to make certain that patients are getting adequate vitamins. Low vitamin B12, for instance, can cause dizziness and fatigue, so can low vitamin D, low iron stores the same. So you need to make sure that you're getting the correct balance of vitamins and minerals. Now, the big one that everyone hates talking about when they come to clinic is activity. And I am going to go into this a bit more because it does have a massive impact on people. So it's the D word and nobody likes it. Deconditioning is a big problem in patients with chronic orthostatic intolerance because it's not very nice standing up sometimes, and therefore sometimes people do less activity. The problem is that inactivity and bed rest are unnatural states. it results in reduced functional capacity and results in negative consequences. Now this slide just looks like a load of medical jargon, but I'm going to demonstrate on the next slide what happens if you spend 24 hours in bed. So we know that if you spend a week in bed, you'll get a decrease in musculoskeletal, so your muscle mass will decrease by 10 to 20%. It's worse in the postural muscles, so the ones that hold you up, and you get loss of bone density. But if you spend 24 hours in bed, you'll get an increase in heart rate, decreased blood volume, decreased stroke volume, so the amount of blood coming out of your heart is less, and you get orthostatic hypotension, so low blood pressure when you stand up. And other changes to your skin, gastroenterological tract, depression, loss of control, loss of motivation, and helplessness. Now, the problem is that we see lots of people in the clinic who are deconditioned, but they're frightened to get up and do things because of the symptoms they're getting. And so we really do have to encourage people to do some activity. Now, it's not possible in everybody because some people have chronic fatigue syndrome, for example, where if they do activity, it makes them very fatigued and they pay for it the next day. So we don't quite know why some people find it difficult to exercise. And I know that the team in Coventry with Helen are going to be doing a study on this and exercise in patients with PoTS. But what we do know, in some patients, exercise and activity can have a really good outcome. But the problem is sometimes you have to start at a very, very low level. And you might only be able to do 30 seconds or a minute of exercise a day, but you need to start somewhere. We have recently had a lady in clinic who I have known for the 10 years that I have been doing this clinic. And we have tried her on every medication known to man. And she's always been intolerant. And then one day last year, she decided to start to go to the gym, and she is a different person. She is up, about, and she's doing really well. And it just shows you how well it can work. And the problem is, when somebody becomes deconditioned, it sets up a vicious cycle. So you don't feel very well, so you don't get out of bed. Then when you try to get out of bed, your heart rate increases, your blood pressure drops because you've got a bit deconditioned, and that makes you want to lie down again. Now, it is a vicious cycle and it's really hard. And the problem is sometimes the exercise can be quite grim. And we know there is quite a lot of evidence that exercise is good for people in PoTS, but we also know that it's quite grim when you first start, and it can be not very pleasant for a few weeks. Anyway, I'll move on because I know that can be a contentious subject. So in clinic, we would do quite a few tests quite often. We will always do a tilt table test on everyone and an active stand test. We usually do Holter monitoring. So you wear a monitoring device for perhaps 2 or 3 days. And what we do is we ask you to write down your symptoms, and then we can correlate your symptoms with what's happening on the monitor, and then we can show that to you. And sometimes that can be very reassuring to people. We usually do a heart scan. The new EDS guidelines want to know what's happening with the structure of the heart in terms of getting points for the diagnosis of EDS. So that's always something that we would do. We always do a heart trace. Of course, we're always looking to make sure we've got the right diagnosis. And so we do a heart trace to make sure that we're not missing something that we should be dealing with. In our clinic, we do a lot of 24-hour blood pressure monitoring, particularly for people who are on drugs that increase the blood pressure. And what we do is we ask them to say when they're getting symptoms, so we can try and correlate the blood pressure to when the symptoms are. And in fact, we are about to buy some very clever blood pressure monitoring. The patient wears it, and when they stand up, the monitor knows they're standing up and will do a blood pressure automatically. So we're quite excited about that. We always like baseline blood tests: kidney function, liver function, thyroid function, blood count, iron stores, vitamin B12, cortisol, vitamin D. And that's because, as I said before, we're trying to get the diagnosis correct. And what we don't want to do is diagnose somebody with PoTS when actually there's something else going on that needs treating. So we need to make sure you've got enough iron. We need to know that your vitamin B12 is normal. Your cortisol level, low cortisol can cause low blood pressure and high heart rate. So that's really important that we know that that's okay. Vitamin D can cause, low vitamin D can cause fatigue and muscle pain, low vitamin B12 dizziness and fatigue as well. It's really important that we look at those and make sure that those are dealt with. 24-hour urine tests, we often ask people to do 24-hour urines to look at how much salt they're excreting, and also sometimes to look at the adrenal function. So moving on, we might have seen you in clinic, we'll have asked all those questions, we'll have done tests, we'll have asked you to take more fluids and salt, done the counter manoeuvres, all that sort of stuff. We will usually see people sort of 2 months after we've seen them initially, just to give them a diagnosis and see how they're getting on. And then there may or may not be consideration of medications. We have a big role in medications because a lot of the medications that are given in PoTS are used off license, which means that most people don't really realise that they're given for this indication and they need special attention. So our role in the specialist clinic is to initiate medications, tell you how they work, what the side effects are, advise you about not taking drugs in event of pregnancy and breastfeeding and preconception. That's really important. And then we monitor the drugs. In our clinic, we phone people up 4 to 6 weeks after the drugs have been started to see how well they are getting on with the drugs and see whether there are any tweakings needed, are there any side effects. And what we do is we increase or decrease the dose according to the effect and lifestyle. So say, for example, we see lots of patients from other centres who come to us on midodrine. Now, quite often we find people who are taking midodrine and they're taking it breakfast, dinner and tea. Now, midodrine won't work properly if you take it like that. Midodrine will only work for a maximum of about 3 to 4 hours. So we need to get that timing right for the patient. We need to look at what time they get up and what time they go to bed. They might need 3, 4, 5 doses during the day according to what time they get up and go to bed. Most of the drugs that you give in PoTS, you need to give to people when they are up and active and not when they are lying in bed. So we need to make sure that we maximise the amount of effect the patient gets when they get the drug. So let's say if someone has to get up at 5 a.m. in the morning to go to work, then we would envisage they take their midodrine at 5 a.m. and then they take it either 3 to 4 hours after that. So they might take 4 doses before they go to bed at, say, perhaps 9 in the evening. So what we do is we always start people on midodrine every 4 hours, and then we ring them and make sure, A, they've not had any side effects. Is it working? Is it making them feel a bit better? And then what we do is move the timings so that we know that they're getting a continuous amount of midodrine rather than symptoms starting to reoccur at the end of the dose and then them waiting to take another dose of the midodrine. So they might take the midodrine 3 hours or 4 hourly, but leaving it 5 or 6 hours means that there will be at least 2 hours where the medication's not working at all. The same with ivabradine. We have found that ivabradine works better when you take it little and often. So having 2 doses a day, usually people will take it at breakfast and night time. Well, most people don't need a dose at night time because when you need the ivabradine is when you're up and about and the heart rate's higher. So what we tend to do is divide it into littler doses. So we start off with half a tablet, 2.5 milligrams, every 4 hours. And we find in the majority of patients that has an effect. And then what we do is we titrate it and maybe increase some of the doses to cover when perhaps they're getting up first thing in the morning or they might do something in the afternoon that they need to. So again, little and often helps. Fludrocortisone, you only take it once a day, but it needs taken first thing in the morning. And again, we ring people up to monitor how it's done with them, have they had any side effects, etc. Other drugs that we might recommend that we would monitor are drugs for mast cells, such as cetirizine and loratadine as an H1 antagonist, and ranitidine, which unfortunately we're having lots of problems with at the moment because there is no ranitidine in the country as far as I can make out. And our pharmacy is recommending famotidine instead as a histamine 2 antagonist. And again, we would monitor those drugs. Right, let's go on to the next slide. So the last thing I have to say is I'm going to answer the questions, but we have had a lot of questions about masks in the current COVID crisis. And I think from just talking to Vicky earlier, obviously different countries have got different rules about masks. But I think some patients with PoTS are finding it quite difficult to breathe with the masks on. However, Leslie Cavey, I know, is looking into this, and what we'll do is I'll ask Leslie to try and post something if we find something out about it. What I've suggested to a few patients is obviously you need to wear a mask if you're in an area where you can't socially distance. And the best thing might be is to wear something around your neck that you can pull up and cover your face with for if you can't social distance. But let's say if you're doing your daily walk or your daily jaunt up the street, you're unlikely to be less than 2 meters away from somebody. And so you don't really need to wear a face covering then. But obviously, if you want to go out and go somewhere where you're going to be a bit closer, you will do. And so I think we need to wait and see what the experts say about that one. Anyway, I am going to look at these questions and answers now. I might just hand you back to Vicky a minute while I just have a look at the questions and answers and see what I can answer here.
That's brilliant. Thank you very much for that, Mel.
Right, so the first question I've got is, do you want me to say names or shall I just answer the questions?
Maybe if you just read out the first name, and we have a few from the anonymous attendees.
Yeah.
I think we have about 19 in the Q&A section at the bottom.
Okay, right. Farah says, I get lightheaded after eating meals. Do you have any advice for this? Well, when you eat, if you have 3 big meals a day, what happens is often the blood is taken into the gut to digest your meal, and then you'll get lightheaded afterwards because there's not as much blood going around all the other bits. So we would suggest that you eat little and often rather than big and not so often. So basically your whatever 3 meals you have a day, eat over 6 meals a day if you can, sort of 6 snacks as it were. And that's one way to deal with it. I hope that helps. Anonymous attendee has said, can I do anything to help with slow bowel associated with PoTS? Well, slow bowel, one of the things that we find a lot of patients who have slow bowel is they're on opiates and things like cocodamol, Oromorph, all those tramadol, all those can help make the bowel very slow. Unfortunately, I am not a bowel expert and I don't think I've got anything else to say on that. The only other thing that I would say is that some patients have come back to us and said when they've had a gluten-free diet that it has helped. So sorry I haven't been able to help much. Anonymous attendee, next one says, I've been feeling exhausted, but my GP says PoTS doesn't cause tiredness. Is this the case? No, lots of people feel very exhausted with PoTS. That is true. But it's really important, as I said earlier, to make sure that there's nothing else causing the tiredness. So first of all, low vitamin D, low vitamin B12, make sure your iron stores are all right. And the other thing is, lots of patients have low blood pressure that can cause fatigue and tiredness. So you need to speak to someone about whether your blood pressure is low as well. Sometimes people just are tired because that's the nature of the beast. But it's important that you get it checked out to make sure there's no other causes. Next one, how do I scroll up and down on this? Oh, do I have to put?
Just roll your mouse over the side of the Q&A box.
Oh yeah, I've got it.
Will pop
Yeah,
up.
yeah. I know Andy Lund, one of our nurse specialists, is watching this, and he will be laughing because he thinks I'm a complete Luddite when it comes to technology.
You're doing brilliant, Mel, don't worry.
Will PoTS cause gut issues for life? Do you know, I don't honestly know the answer to that, but unfortunately, I suspect it might. I don't really, I think that is a a gastroenterologist would be able to answer that better than me. Right, does POTS go away if you developed it as an adult? Anonymous attendee again. Okay, so there are lots of reasons why people have POTS. The biggest one that we tend to see is people who are hypermobile, but some people develop POTS as a result of a viral infection. And unfortunately, I think that this is going to be a consequence of COVID. And I think we're going to be seeing more people in the POTS clinic. If you have developed it as a result of a viral infection, it can go away. About 60% of people will recover, but it does take 3 to 5 years to recover, I'm afraid. And I think it's difficult to know if POTS goes away. Some people it does. It depends how you manage it. Some people it doesn't. I don't think anyone really knows, to be honest. So I'm afraid that's not really a very good answer either. It's probably an honest one. Next one from Taryn. I lose my memory when my heart rate raises to a fast pace and it can last a period of time. Is this part of POTS? Well, it's probably because there's less blood going to your brain because your heart rate's so fast. And I would suspect that it probably is. Jenny has asked, what can I do to reduce excessive sweating? That's a really difficult one. The first thing I would say is make sure that you have had things checked to make sure you're not excessively sweating due to other reasons, but also look at your drugs. Things like sertraline can cause excessive sweating. And I think being treated, we've had a few patients who've had excessive sweating, and actually treating them properly for POTS has helped the excessive sweating be reduced. So unfortunately, lots of patients with POTS have lots of different problems, and there's no rhyme or reason sometimes as to why they work with some people and not others. Right, so next question from Anonymous is, I'm a uni student and attend a POTS clinic. When I graduate, is it possible to attend a POTS clinic closer to home? How would I go about this? Well, you will need to look on the doctor's list and see if there's anyone nearer home. Like I said before, there is that list. There aren't many doctors and people do have to travel. If you want to move, you will need to speak to your GP and they will need to refer you to the new clinic. But the list is on the website and you need to speak to your GP about it. Next one from Clara. Will clinics take GP referrals from the Republic of Ireland? I don't think I know the answer to that, actually. I think you would have to get funding for that. And that might be one that Leslie might need to answer later. But I think because the Republic of Ireland is in Europe, that might make it difficult. I don't know. There's lots of rules and regulations about these things that I'm not really very sure of. All I can say is if someone gets referred to our clinic and someone's happy to fund it, we're happy to see them. Right, Nicola has said, my referral for tilt table has been put on hold since January due to COVID. Any idea when I might get seen? Also, is POTS orthostatic intolerance variable or the same all the time? I've had bad patches. Right, what I'm going to do with this is answer these questions individually. My referral for tilt table test has been put on hold since January due to COVID. I don't know what other hospitals are doing, but we're certainly doing tilt table tests in our institution and have been doing for a good 3 or 4 weeks now. So there'll probably be a backlog and your name will be somewhere on that list with the backlog. But I can't speak for other hospitals. Is POTS orthostatic intolerance variable or the same all the time? No, it's variable. Some people have good days, some people have bad days. I have bad patches and good days, and I had a 24-hour test last year, which they did on one of my 24 good days in the whole of 2019. So obviously I'm worried that the tilt table test will also miss when I actually have symptoms. So is this variability taken into account? I think that's a very difficult one. I mean, the chances are, if you've only had 24 good days last year, the chance of you having a tilt when you're not having a good day is quite high. Certainly in our clinic, if someone says they're having a good day, we will usually say, do another tilt, or we'll wait till you're going through a bad patch and see what we can do. That's what we would say anyway. What can I do to get help with breathlessness? Anonymous attendee. Now, what we do know is that some patients with PoTS suffer from quite severe shortness of breath. Now, in my experience, if you slow the heart rate down adequately, the breathlessness can be helped. But there is another thing with this, in that some patients suffer from dysfunctional breathing. So if you imagine that in PoTS, the autonomic nervous system isn't working efficiently, it can also work inefficiently in controlling the breathing rate and rhythm. And so it might be worth making sure your heart rate is controlled properly, and then being referred to a respiratory physician who can assess you for dysfunctional breathing. Jill, oh, I know Jill. Can I get my almost 16-year-old to be seen in Sheffield? We live in Derby. She was diagnosed with PoTS in May. Yes, Jill. If your GP refers for a second opinion, that will be fine, I would have thought. Debbie says, shouldn't people have a Doppler to check ABPI before wearing any compression stockings, even class 1? Debbie, in young people, it shouldn't be a problem. It's just in older people where there might be a problem with foot pulses. As a rule, we don't tend to check them in our clinic, but obviously if it's someone that's older, we do. Anonymous again, can you see young adults from Northern Ireland? No appropriate specialist care at present, and feel we need appropriate input for diagnosis and treatment. Again, this is the Scotland-Wales thing. It is something I know PoTS UK are working on. What you need to do is secure funding to be seen in England by a PoTS specialist. And there are a few of us that will see people that are referred from out of area for a second opinion, yeah. Right, next one is Jo. She's emailed the question. My question is regarding transient PoTS symptoms or PoTS suddenly worsening. If I do in fact have it, my GP suspects I do, and they're doing a lot of tests to rule out other cardiac issues. Why has it suddenly got worse? I've been getting more fit. I'm 14 months out from my most recent concussion. I believe I've had PoTS before and recovered from it many years ago. It's difficult for me to answer that because I don't know the full history, and obviously there's a history of concussion here. And there is post-concussion syndrome to think about as well. So what we find is with people with PoTS is that it tends to wax and wane rather than go away and come back. So I'm not really sure I can answer that fully. Next question is Libby. I've just been diagnosed with PoTS as a result of COVID-19 and I'm into my 15th week of symptoms. I'm considered to be a long sufferer of COVID-19. I just wanted a bit of advice on how to manage PoTS symptoms alongside recovering with post-viral fatigue. I'm unsure how to pace activity and don't want to make any symptoms worse and potentially lead to CFS. I think this is going to be difficult. I think it's going to be something that we see in clinic quite a lot. Yes, pacing is important. I think it would be important to be referred to a physiotherapist or someone who could help you with that pacing. Unfortunately, it is a slow, long recovery, but some activity is necessary to get things going again. And I would advise fluids and salt, obviously, compression stockings or tights if you can take them. And sometimes You know, we have to give people drugs for their POTS symptoms to get them back on their feet. And actually, we have quite a lot of success. We're giving lots of people drugs to help them get back on their feet, either with a heart rate or giving them some blood pressure drugs. And then they can do their activity, and then they come off the drugs because they feel better once they've done some activity. So that might be what's required. Next one is Jennifer. Where can I find the closest POTS clinic to Kent? I've seen Prof Matthias at the Autonomic Centre to be assessed and diagnosed originally, but a clinic with someone like you would be amazing, as there's no hereabouts that knows about it. Again, this is on the doctor's, the link that I put on that slide. This is why I haven't put any fancy bits on the slide in case people want to screenshot them. It'll be easier to see the link. Like I say, there aren't many of us. People have to travel, and you will just need to look on that list and just see where the closest one is to you, or one that you could reach. I mean, you might have a relative somewhere else in the country that you could stay with overnight if you would see someone elsewhere. Next one is Jennifer. Again, what exactly would midodrine be prescribed for, please? Midodrine is only prescribed for people with low blood pressure. It should not be prescribed for anything else. In our clinic, we are very, what's the word? We're quite persistent in trying to find out if people have got low blood pressure, because midodrine can cause high blood pressure, and that's something that people don't want either. So we look for objective evidence, so that means something we can see that tells us someone's got low blood pressure. So it should only be prescribed for low blood pressure. Next question is from Anonymous. What should I do if you go on a walk and then you start getting faint and can't breathe? I think it's always important to deal with it by using counter manoeuvres and sitting down. So what I would suggest is that you take with you something to sit on, like a plastic bag or something like that. And then, unfortunately, you'll have to sit yourself down and let things settle. It might sometimes, it may be that being in that situation when you're outside makes you feel really quite anxious as well. I think it would do me. And it may be worth trying some relaxation exercises as well while you do it, just so that any anxiety you've got about it happening when you're out for a walk doesn't feed back into the symptoms and make them worse. I think that would be a good one. Unfortunately, I think it's embarrassing. People feel embarrassed about it because they've got to sit down, perhaps in the middle of a path or on a wall or something, and then everyone's looking at you. Well, it's probably better than passing out or being really ill. So I just think a plastic bag to sit on is something that you could do with counter manoeuvres. Make sure you always take a drink with you, and perhaps something like some peanuts or something that have got salt on, and then recover. And don't stand up again until you feel you can. And always make sure you've got your mobile phone as well, so that you could call for help if you need to. Next one is from Natalia. Can people from Scotland come to our clinic? Would you help with referrals from Scotland? So what you have to do if you want to be referred to a clinic in England from Scotland is your GP needs to get funding from the health authority or whatever it's called now. I can never keep up to date with these things. And then your GP can refer you to a clinic in England once funding has been secured. Basically, your GP has to say that there's nowhere in Scotland for you to get this treatment. Emma, do you recommend regular monitoring vitamin B12, iron and vitamin D? We would generally tend to check them every year in our clinic, or get the GP to check them, but yes, I would recommend that they're done. And just to make sure everything's okay on that respect. Anne, what's the alternative to ranitidine and what doses should you take and how? At the moment, the famotidine is the one that we are being recommended by our pharmacy, and it's 20 milligrams twice a day. However, I understand it's also quite difficult to get hold of. Currently, we are doing a letter that goes out to pharmacy and people with those sort of queries. Unfortunately, I think what's going to happen in a lot of patients is that they will be not taking anything because there won't be any other alternatives. Certainly, cimetidine is not an alternative. It's got too many interactions with other medications. Adam, currently waiting my tilt table test and given propranolol. Would this affect the test results? I wouldn't want a tilt table test while someone was taking a drug such as propranolol. First of all, it decreases your heart rate, and secondly, it decreases your blood pressure. So if that was us in our clinic, we would want you off the propranolol to do the tilt table test. Otherwise, you're never really going to know what's going on. So that's that one. Sorry, I'm whizzing through these now because there's loads of them. Anonymous attendee, problems with blood pooling, which is also always relieved by raising my legs and compression garments. That's fine. Blood pooling also causes rashes with me, but as I have a separate diagnosis of HSD and surgeons, it's difficult to attribute to POTS. Are you aware of other POTS patients who develop rashes with blood pooling? I don't develop the rashes without the blood pooling. I don't think I really know the answer to that, if I'm honest. It may be that there's an element of mast cell activation syndrome going on. I don't know, is the answer to that. I'm being honest, I don't know. I'm afraid. There are a couple here that we might have to spring to Leslie. Jill, I've been improving from bedbound to housebound since February 2020. Well done, you. Via physio and salt. It's improving, but it's so slow. Yeah, I think that's one of the problems, and it can be demotivating when it's really slow and make you feel a bit low. Should I ask for medicine to help speed things up or persevere without since things are improving? Well, things are improving. It's amazing that you've got from bedbound to housebound. That's absolutely fantastic. Make sure you're taking enough fluids. Medicines might help if you can get to the point where you could have a tilt or some sort of test that would say what the problem is. Is it low blood pressure? Is it high heart rate? And if it's either of those, they could be treated to help give you a bit of a boost. But carry on, you're doing a fantastic job. It sounds amazing. Anonymous, is there a link between folic acid anemia and POTS? I was exhausted. My folic acid is very low and I'm not sure there's a link. Well, I have to say we find a lot of people with low folic acid. Now, low folic acid can be an indication that you've got celiac. And when we did our study on patients with for gluten intolerance, we also found that patients had a higher incidence of celiac in the POTS population. So it's very important to be tested for celiac. So it might be worth going back to your GP and saying, why is my folic acid low? Have I been checked for celiac? And take it from there. Anonymous wants to know what the benefits of redoing testing if you already have a diagnosis. We get lots of patients come to our clinic, and this is why we redo tests, who have been told they've got a diagnosis of POTS. Perhaps I'm being rude here by people who don't see lots of patients with POTS. So from our perspective, we want to get the diagnosis absolutely correct and make sure we are telling you absolutely what is going on. And I think being labelled with a chronic illness when you haven't got a chronic illness can be as bad as not being labelled with POTS when you have got it. From our perspective, we want to make sure the diagnosis is absolutely correct. And quite often things like tilt table testing are done very poorly in centres where they don't deal with lots of patients with POTS. I've got another patient from Angie about seeing a 15-year-old from Scotland. Again, the answer is you'll need to approach your GP to get funding, and then once funding has been established, the patient can be referred to a centre in England. Hang on, I think I've missed one here, sorry. What's the best way to manage high blood pressure when standing, which goes too low when you're lying down? Hang on. I don't think I'm able to answer that one at the moment because I'm trying to get my head around that, why that should happen. So that's one I'm going to park for now. I need to think about that. Daisy, can I self-refer to the PoTS clinic? My GP isn't very good and often refuses referrals. I'm afraid, Daisy, you can't. It has to go through a GP, or maybe another specialist could refer you if you see somebody else. Maybe if you see a gastro person or a rheumatologist or someone, they could refer you. Or maybe if you attend A&E at any point, they could refer you. But unfortunately, GPs are the gatekeepers, and we've had lots of patients who've had to change their GPs to get in the clinic. Right, Daisy again, I often get confused between PoTS and dysautonomia. Right, so dysautonomia means that the autonomic nervous system doesn't work efficiently. PoTS is a form of dysautonomia, and sometimes we call it dysautonomia because it's not quite PoTS, but we know that something's not quite working efficiently. So the autonomic nervous system's not working efficiently, and it's causing orthostatic intolerance. So dysautonomia is a bit of an umbrella term, and PoTS is part of that. Anonymous wants to know how hyperaginergic PoTS is diagnosed. Well, it's usually diagnosed by, you can have a tilt table test where the blood pressure goes up, and it has to go up by something like more than 20 millimeters, I think, of mercury, the blood pressure on standing, and be sustained. And also people can have lying and standing levels of adrenaline or noradrenaline done, but there are very few centres in the country who do this, and the diagnosis of PoTS can be quite controversial. But I think the best way to deal with it is to make sure that you've got objective evidence that the blood pressure is high, so 24-hour blood pressure monitoring, and that you're getting symptoms, you've had a tilt table test, and then treat the high blood pressure with an old-fashioned antihypertensive, one that works in the brain rather than the periphery, such as clonidine or old-fashioned beta blockers, and see whether they work. Louise says, I've been told to wear class 2 tights. Do I need to wear them every day? And do I wear them at night? You wear them every day if you can, Louise. However, when it was hot recently, I don't think lots of people wore them because they'd probably get very sweaty and very hard to wear. And no, please don't wear them at night. Wear them as much as you can. I would say if you have to stand or on your feet a lot for work, that's when you should wear them. Can compression garments and salt tablets be prescribed? Again, anonymous. Compression garments are always prescribed, and your GP can prescribe them. And salt tablets can be prescribed, but if I'm honest with you, I would prefer that patients take the salt through their diet rather than the tablets. The tablets are a bit like horse pills, and there are always side effects to tablets, as we know. And one of the side effects with those sort of tablets is they can sort of get stuck if you've got slow bowel motility. So I would always prefer someone to try and take salt in their diet if possible first. And Farah said, I get lightheaded after a meal. Do you have any advice? I think I've done that one already. Natalie, have I come back round? Because I'm on Natalie again, who's saying no PoTS specialist in Scotland.
Yeah, I think we may have a few people that have typed their question in a couple of times here,
Right.
just to.
Okay,
yeah,
so
if we skip a couple there, I think we've got repeat questions.
Yeah. So do you work with specialists to educate them, get involved in PoTS research and encourage them to be specialists? I have spoken at the Scottish Cardiac Society in the past, and sometimes get Scottish consultants ringing us to ask advice. So that's Debbie. Should PoTS be reassessed regularly to see if it has improved? If it's on medication, it's hard to know if things have improved or not. My son has been diagnosed for approximately 3 years. He's now 20. Well, if you're in a PoTS clinic that does follow up like ours, we would make sure you followed up and see whether you have improved. And if you have improved to the point where you're off medication, we would discharge you. So, yes, I think it should. That's my personal opinion anyway. Natalie, again, my daughter has mental health issues. Is it safer to take fludrocortisone? Fludrocortisone, one of the side effects is that it can people can suffer from depression, anxiety and irritability, and yes, I would be cautious of that. Louise, I have not been diagnosed with POTS but have symptoms and have done a standing test. My doctor has said next step is compression tights but hasn't said anything else to do. Do I need to ask him for a referral straight away or give it time with the tights and write notes on when things happened? Louise, what I would do is make sure you're taking enough fluid and salt, try the tights, and then give it about 6 to 8 weeks, see if anything happens, and then go back to him. Write it all down.
By the way.
Hey? Natalie, do you have recommendations for B12 and D level? No, they are each area will have a recommendation on for what is normal for vitamin B12 and vitamin D according to the analyzer that they use in the labs. Anonymous, is it possible to make your slides available afterwards? Yes, certainly, that's fine. I've made them so that people can screenshot them and use them. So yeah, that's absolutely fine. Daisy, I take ivabradine and propranolol. Oh, wow. And the doctor wants me to come off my meds for another tilt. Yep. I believe it would be dangerous for me to come off the meds, so should it be done as an inpatient? No, Daisy. Ivabradine is quite short-acting, and I would say don't take any on the morning of the tilt table test. And the propranolol you'll need to wean off because it's a beta blocker, so you need to wean off it over a period of a few days. But ivabradine and propranolol, you need to be very careful using both those together because they can cause very slow heart rates. If you came to our centre, we would want you off both of them to do the tilt table test. Yes. Anonymous, I've been checked for, oh, hang on, I've skipped some here. I seem to have gone to the bottom. Hang on, I've been checked for celiac. My folic acid is still really low. Does celiac sometimes not come up in blood? Yes. When you speak to the doctors that deal with celiac, they do a whole range of tests. So if your folic acid is still very low and you're worried about it, speak to your GP. Clara, is it normal to be less symptomatic at night time? Yes, absolutely, because you're lying down. And POTS is a condition of orthostatic intolerance, i.e., for want of a better phrase, you're not very good at standing up. Anonymous, I'm changing from propranolol to verapamil. GP said to just stop propranolol, start verapamil. Is that okay to do so? As was always told to wean off propranolol. Yeah, beta blockers, you need to wean off them. I'm not really sure why you changed to verapamil either. I wouldn't. That's not a drug we would generally tend to use in the POTS clinic. I would say that if you have POTS and you have a high heart rate, ivabradine if propranolol's not working. Chloe, I've been able to increase my fitness to where I'm now running 5 to 10k. Wow, that's amazing. Still have to lie down as soon as I come in. That's because when you've been running, you get vasodilated and all the blood goes to your muscles and everything. And so that's why you need to do cool down sometimes. So all the blood's in your muscles, and then when you stop, it's not going to your heart, lungs, and all the rest of the places it needs to go to. So yeah, you probably will need to lie down as soon as you come in. My question is, I'm on bisoprolol. I work out when I can, and depending on my mood, sometimes I'm too low to work out, even though I know it can help me. I drink enough, I'm on folic acid, and I do everything I can. How could the clinic help me further? I still struggle with symptoms, but don't know what else is possible to help. So if you would come to a specialist clinic like ours, what we would do is we will probably put you on ivabradine, because the problem with bisoprolol and all beta blockers is it lowers your blood pressure. And if you've got low blood pressure as well going on, then something that lowers your blood pressure more can make it a bit of a problem. So we would cut it right back. We'd unpick everything, go right back to the beginning and try and work out how we can help you more. I'd be looking to see what your blood pressure was doing actually. That would be my thing if you came to us on bisoprolol.
I'm just very mindful of the time now, Mel. We have one
Okay.
last question, if you were able to cover that, and then we'll wrap things up, if
Well,
that's okay with you.
Yeah, there's another about Ireland, which I've already answered. Can
Yep.
POTS still remain severe and unchanged despite doing exercise? I had a doctor tell me I obviously wasn't doing enough, otherwise I would be better. Yes, it can. Some people just don't respond to exercise. But in that case, we need to look at how you can be helped otherwise. So I don't think that's probably very constructive, is it? Being told you're not doing enough. Okay, so I won't answer anymore. I think I have got to the bottom almost. Yep.
If there is anything specific that we have missed, then please feel free to email POTS UK. We have specific email addresses for different things, which you can find on the POTS UK Facebook page at the pinned post at the top. I just want to say a massive thank you, Melloney, from all of the POTS UK team, and on behalf of everyone that's attended today. I'm sure a lot of people have found that really helpful. Thank you so much for doing that for us.
No problem.
Yeah, if there's anything else you need to ask POTS UK, then do feel free to email. And thank you everyone for joining us today.
Thank you. Bye everyone.
Goodbye.